So just a brief overview about OCD. In Singapore, OCD is actually the third most common mental health disorder after depression as well as alcohol abuse, and it affects 1 in 28 Singaporeans. But despite this severe impact of OCD, as well as the prevalence of it in Singapore, most OCD sufferers, they don't seek help. And when they do, they only sought help after many, many years. Okay, so according to a nationwide survey, individuals only seek help after about an average of 11 years. So that's really a significant time before they actually found someone to support them in dealing with their condition. And most likely that this is due to the stigma and shame that the individuals have because of their condition. And also there might be a lot of difficulties recognizing OCD, because a survey has also found that only about 28.7% of people can recognize OCD symptoms when they were given a description about it. So again, it might be due to stigma, it might be because of shame, as well as the poor recognition of it as a disorder. Okay, so what exactly is OCD? So OCD is a mental health condition that consists of two parts, obsessions as well as compulsions. So obsessions are recurrent and persistent thoughts, urges, or images that are experienced as very intrusive, very unwanted. And individuals oftentimes increase a very heightened sense of anxiety or distress, emotional distress as a result of these thoughts. So due to the distressing nature of the obsessions, the individual will often then try to ignore or suppress the thoughts, urges, or images, or because they are so recurrent, persistent, and intrusive, the individual might also try to neutralize them, so to get rid of them by using some kind of a thought replacement or using an action, which brings us to what we call the compulsions. Okay, so what are compulsions? Compulsions are really repetitive behaviors, or they can also take the form of mental acts. So repetitive behaviors such as hand washing, such as checking, mental acts are such as counting silently or repeating words silently to themselves that the individual will perform in response to their obsessions. And these are usually applied very rigidly according to the content of their obsession. The compulsions are aiming at reducing the anxiety or distress created by the obsessions, or perhaps they're also aimed at preventing some kind of a dreaded outcome that could happen. So, but these compulsions are usually not really very effective in neutralizing these scenarios that could happen, and oftentimes are very excessive. Okay. So let's first understand a little bit about how the obsessions as well as the compulsions play together to keep the OCD going. So I'll just illustrate this with an example here. So take, for instance, a person with OCD may be getting on with everyday life and just taking the bus. This situation itself might trigger an obsession. So they might start having thoughts that, wow, the handrail may be full of germs. And if I accidentally touch it, the germs will be transferred to my hands. If I use these hands and use my hand to eat something, or if I accidentally touch my mouth with it, I might ingest the germs. I might die from it eventually. Or even worse, I might carry the germs on my clothes. I might bring them home. And if my family members touches these objects or touches me, they might also get sick and die. So such obsessions would definitely then result in anxiety, distress because of that feared consequences, which, okay, sometimes it also manifests as disgust rather than anxiety or distress. But then this all the time triggers a need to do something then about it. Okay, so for example, in this case again, a person may then try to sanitize their hands or wash their hands after alighting from the bus, perhaps repeatedly so, until it feels like it's clean enough or feels like it's just right. So they might also reassure themselves repeatedly that nothing will happen, or they might seek reassurance from other people that nothing is going to happen to them or to their loved ones. So eventually, they might also start avoiding touching anything in the bus, or in more severe cases, they might just choose not to take the public transport at all. So they will not be at the risk of touching anything. But after engaging in these compulsions, usually what happens is then they experience an immediate relief. The anxiety goes down, the distress goes down. But this is only temporary because the obsessions will come back again when another situation hits, and the cycle then continues. So we can see how debilitating OCD can be, especially when the person is unable to take public transport because of these fears about the germs that might be there. So if the person cannot take public transport, we can imagine how this can impact on how they are going about work, how they're going about school, how it's going to impact on their social life as well. So we can see very severe outcomes when the person is dealing with some of these OCD obsessions and compulsions. So looking at this graph here, the portion highlighted in red, okay, we can see that each time that the person has an obsession, okay, the anxiety levels will increase here, okay, the anxiety rises. Then the person will try to avoid or engage in compulsions, and immediately there will be a relief from this anxiety, okay, so it immediately comes down. However, it does not allow the person with OCD to learn to cope with this anxiety. So which means the next time that the obsession occurs again, the same cycle repeats. So the anxiety level goes up again. We have to use the rituals or the compulsions to come down, to the anxiety levels to come down. And then again, the cycle repeats and repeats. So in the end, the anxiety and distress never really goes away in the long run. Okay. So after my previous example, you might be wondering if you have OCD because you might have been washing your hands after being on public transport as well. I mean, now with the COVID-19 situation, I think hand washing, sanitizing has also become a new norm for most of us. It is necessary to protect ourselves from the virus. So how then do we draw the distinction between what is OCD and what is not? Actually, even COVID aside, if you think about it, we all definitely have moments whereby we are also experiencing intrusive thoughts, worries, or magical thinking. So for example, I mean, this is something that I do as well. We may accidentally talk about a bad situation that might happen, and then we will think that we have jinxed ourselves. And then we try to undo it by saying choy, or we touch wood. So perhaps, or we also have a lucky tie or a lucky pen that we might bring to exams or bring to presentations that will supposedly help us get through things a little bit smoother. So all this sort of intrusive thoughts, magical thinking does not necessarily mean that you have OCD though, because it's a lot more complex than that. It's a lot more severe and debilitating. And a lot of times they are in a lot of distress as they are performing these compulsions. Okay, the individuals are in a lot of distress when we are doing this. So for it to qualify as a disorder, the obsessions and compulsions have to be very time consuming, whereby it's taking up to more than an hour every day. They also cause a lot of significant levels of distress, as well as significant impairments in different areas of life. So for instance, one may experience difficulties in their social life because they are always asking for reassurance, or they might be avoiding certain activities just to not trigger their obsessions. Okay. They might be spending a long time on their compulsions that causes them to be unable to work or study properly. So when we talk about OCD, I think immediately most people first think of washing or cleaning repeatedly with the fear of contamination and dirt. However, OCD can also take other forms. So some of the subtypes, aside from the contamination one, are also about aggressive or horrific thoughts about harming others or oneself. So for example, some individuals might mentally review whether they have knocked down anyone when they were going about their day-to-day life. So in their mind, they might play out again what has happened in the day and ensuring that they didn't hurt anybody in that day. So another one is the need for symmetry, ordering, and counting, whereby there's a need to feel that things are just right, or that certain numbers are good, there might be certain numbers are bad. And the last one is about having blasphemous thoughts, which involve being disrespectful to religious or sacred things, as well as having forbidden sexual thoughts. So similarly, to counter these OCD fears, there are also compulsions, common compulsions that we see. So one of which will be the washing, excessive washing and cleaning. Some people might tap or count just the right number of times to undo certain of these obsession fear outcomes that could happen. Individuals might also check very frequently, such as if they have checked, they might check whether they have locked the door several times, checking whether the stove is off. And just now in the example I mentioned, mentally reviewing, checking whether they have knocked down someone in that day or sometimes compulsions, and also they might also mentally try to replace a bad thought with a good thought or good image. Perhaps they might also repeat a prayer mentally over and over again. Sometimes we might notice that the compulsions are not necessarily observable. So they can take mental forms whereby the person is just in their mind doing some of these things, such as the prayer, such as replacing bad thoughts. That's what we saw as mental acts. And frequently, we do see that people also seek reassurance. So from themselves or from other people that things are okay. Okay. So it is also possible that at a certain point in time, we don't see any compulsions for the individual anymore. Now, that's not to say that it doesn't exist. Sometimes individuals might just try to avoid the triggers altogether. So they don't even trigger their obsession in the first place, so as to not start their compulsions. But there's a difficulty in that because these individuals may then start to avoid major activities in life in order to not trigger their OCD. Okay? So it is not helpful as well in this scenario. Okay, so if you think about what contributes to OCD, there might be several things that interact together to contribute to the development of this. Firstly, there is a genetic component to OCD. So the likelihood of a person getting OCD is doubled if he or she has parents, siblings, or children with OCD. And they have noticed also in twin studies that in monozygotic twins, the OCD incidence can be as high as 57%, and in dizygotic twins, about 22%. But notice that it is not 100% chance that you will develop OCD, even if you have a family member with the condition. So it suggests that there are other factors at play, aside from the genetic makeup. So events that happen in one's environment, such as childhood trauma, difficult life circumstances, infections, can also lead to OCD symptoms. And like most mental health disorders, stress, life stresses can also precipitate OCD and make OCD worse. So events such as pregnancy, work stress, death of a loved one can also be triggers to OCD as well. Okay, and we'll notice that OCD tends to first occur in the younger population. So it peaks at about 10 to 12 years old, as well as late teens. And adults who seek help for OCD also recall having OCD symptoms when they were much younger. Perhaps some of this went away by itself, or perhaps they were still able to function, even though there were mild OCD symptoms happening. So a lot of times there is also shame and embarrassment about their condition. Individuals often think that they are crazy or even bad for having this kind of intrusive thoughts. So imagine having intrusive sexual thoughts or thoughts about harming other people. There's definitely going to be a lot of shame and guilt that you even have such thoughts, because the individual might deem this as very unacceptable thoughts to have. In my practice, I have actually found that individuals with OCD are the most caring people I have met. OCD has actually used their care for other people as a threat against them. Okay, so moving on, we're going to talk about the treatment. So OCD is typically a chronic condition with long-term waxing and waning outcomes. However, you might notice that the obsessions and compulsions change over time. And without treatment, the remission rate is low at about 20%. With treatment, individuals can usually learn to identify when their OCD symptoms are recurring and then actively take steps to overcome this. Okay, so there are several different types of treatment. First of all, the medication. There are a few classes of medication that are frequently used in the treatment of OCD. This includes SSRIs, tricyclic antidepressants, SNRIs. But typically, psychotherapy is recommended as a first-line treatment for OCD. But medications are often very helpful when a patient is not ready or not keen for psychotherapy yet. And medication can also help to improve the responses to psychotherapy, or when there are other existing conditions as well. Medication is also very powerful in that case. So we also want to involve the family in family interventions because OCD often recruits family members as well into performing the compulsions alongside the person. So usually treatment will take a combination of all of this intervention. But for the purpose of the next segment, I will be largely talking about psychotherapy because that's what I'm trained in doing for the following segment. Okay, so psychotherapy, there are many different types of psychotherapies that are available. For OCD, the gold standard treatment by the NIC guidelines is what we call exposure response prevention, or ERP for short. ERP is an evidence-based treatment which have been found to be very effective in treating OCD. Okay, so here's a few studies that I'll be sharing. In a randomized controlled trial where participants with OCD received 17 sessions of either stress management training or ERP, ERP was demonstrated, so the red line was demonstrated to be more superior to the stress management training in reducing OCD symptoms. You can see that the red line is more steep than the blue line, which is the stress management training. And in another study, we can also see here that clomipramine, which is a medication used to treat OCD, okay, indicated by the green line over here. Okay, the green line over here is also effective in reducing OCD symptoms as compared to the blue line, which is the placebo group that's not actually given any active treatment. And even more effective is what we can see, the yellow line over here, which is the exposure and response prevention, or ERP. It's even more effective in reducing OCD symptoms. And we notice over here the red line, which is both medication with ERP, has about the same effects as ERP alone. Okay, so this tells us that ERP is definitely very effective in treating OCD. However, note that it does not mean that medication in this case is not helpful. It is particularly helpful when the person is really not ready to be doing ERP because it can be quite confronting and can be quite anxiety-provoking when we are doing ERP, which I'll explain a little bit more in the next segment. Okay, so just to share with you how does the exposure and response prevention work in breaking the cycle. Okay, so if you remember this graph from before, we were talking about this jagged portion over here, whereby the anxiety rises, compulsions will reduce the anxiety, and then the next time around, the anxiety rises again for that individual. So in the short term, it's effective, but in the longer term, the cycle keeps repeating. So in ERP, we are going to look at this graph over here, this rounded graph on top. As the name suggests, exposure will involve exposing the individual to situations that will trigger the obsessional thoughts. However, this time around, we are not letting them avoid it. Okay, we are trying to target the avoidance in this individual so they actually learn how to manage the distress from the obsessions. Okay, this is because when they are always avoiding, they never really get to learn that they can manage the anxiety or distress. So response prevention. Okay, response prevention would mean that the person don't engage in a compulsion after doing the exposure. So this again helps the person learn that they can manage the anxiety without the need to do a compulsion. So what the person is learning is that eventually anxiety will rise, okay, but then it will come down again by itself. Okay, just to illustrate, an example of exposure might be, for example, an individual who might be worried about harming other people accidentally, and hence perhaps their compulsion could be turning back repeatedly when they are walking just to check that they have not hurt anyone. An example of exposure might be, you might get him to bump into someone, and then an example of response prevention would be to continue walking without checking. Okay, and learning to sit with the anxiety and the distress of not knowing. So the first time that we do ERP, it's likely that the person is going to feel very anxious. Okay, when we do our exposure, anxiety is likely to increase. But because we are doing response prevention, it means that and we are not engaging in compulsions, it means that the anxiety does not go down. It will continue to stay high. However, in ERP, we'll stay with the anxiety because what we know is anxiety will reduce on its own at some point, even if we do not do anything about it. This is the nature of anxiety. Okay, but for some people, it may take longer. Some people, it is faster, but eventually it will come down and we just have to wait it out. Okay. And in ERP, we are not going to do this just once. We are going to do this repeatedly, again and again. So next time round, we still go through the same cycle, but the anxiety might not peak as high because we have repeated it. We don't get as fearful. Eventually, the person will learn to manage the anxiety from the obsessions and the anxiety will reduce. The person also eventually learn that they don't have to rely on compulsions in order to make the anxiety go away. Okay, so by this time, you might be thinking that it's really scary and that there's no way that you're going to attempt this on your own, or you're never going to do this exposure. Or for family members, you might also be thinking, hey, I can do this at home with my loved one. I can just stop them from engaging in the compulsions altogether. So I'll say hold your horses, because ERP is not so direct. It is a very collaborative process where you work together with a mental health professional in a graded manner. Okay, so starting with situations that are easier, starting with situations that might not be so challenging, we are going to eventually move up the ladder of difficulty. So to illustrate an example of what we call graded difficulty might be for a person with contamination fear, instead of touching the object that might be dirty, we might get a piece of tissue and using that tissue to touch that piece of object, and then getting the person to touch that tissue instead of the object directly. If that is still too challenging to break it down further, we might get a second piece of tissue and touch this contaminated first piece of tissue, and then get that person to touch that second piece of tissue instead. So you can see how it is really going to progress at a pace that is comfortable for that person as well. Okay, so we don't want to go full blown, because that's going to be extremely distressing and anxiety provoking for the person. So again, important is that therapy will always progress at a pace that is more comfortable for the individual. So there's a lot of individualization involved in this therapy. So the intensity of therapy might depend on the severity. It can be as frequent as once a week. Additionally, the individual will also have to continue ERP on their own at home as well, in between sessions, so that to sustain the learning. Because you can imagine if, let's say, they only practice it when they are in session, that's not going to be enough times for us to repeat these exposures. Treatment length also varies depending on severity. Some can be as short as 8 sessions. Sometimes it can go up to years. The ERP can be done in a clinic. It can also be done at home. It can also be done in community settings, depending on what the individual needs. So what we saw a lot of times is patients actually say it's easier to do the exposure task in clinic compared to where they are at home, because the OCD kind of lives in the home. So in such cases, we'll aim to continue with ERP at home eventually, as we want the person to be able to generalize the learning across different settings. And OCD also often causes people to put a pause on their life, and individuals then find themselves no longer being engaged in life activities. They don't do the healthy stuff that they used to do, such as exercising or going out with friends, because this could trigger their obsessions. But at the same time, we want to continue living a healthy life and return to what we call the life lane before OCD happened. So resuming activities is also a form of doing ERP. And in session, we are going to be discussing this a lot as well. So one example would be if we play basketball and the ball bounces onto the floor, so it's contaminated, and the individual will have to touch the ball, which is an exposure for someone with a contamination fear. But in order to allow the game to continue, they will not be able to sanitize their hands or wash them right away. So again, we are getting them to tolerate the distress and learn to manage the anxiety without engaging in those compulsions. So engaging in these activities will help one person to help that person to return to their healthy lifestyle and manage their OCD. Okay, and also just to share, there is also now a possibility of doing therapy remotely within the comforts of their own home. IMH OCD clinics has actually developed an internet-based ERP option, whereby there are online modules that you can learn about your OCD and also be supported by the therapist remotely in developing some of this hierarchy, developing some of these tasks that you might want to do the exposure and response prevention on. This program will most likely be rolled out next year. Okay, now let's have a look at how OCD affects families. Because as you can tell already, OCD is very demanding. A lot of time it bullies the individual into following what OCD tells it to do and can cause a lot of distress for that person. And as family members, I think it's only natural that we want to help our loved ones feel less of this distress because it's painful to see them suffer, isn't it? So as such, what we might do is we might engage in what we call accommodative behaviors. So for example, we could engage in the same compulsions. Okay? When we see them in distress about something that they might think is dirty, we could supply them with soap, with sanitizer, with Dettol. Or caregivers might find themselves spending a lot of money on this kind of products. Sometimes we might even help them clean, hoping that it will get them over it faster. If the place remains clean, then maybe they will not be in so much distress. Sometimes we could also have to engage in the same compulsions because they might be worried about harm coming to us, and they insist that we have to carry out some of these cleaning behaviors as well to protect ourselves. Okay, so we might partake in some of these compulsions. Also, we might also assist in avoidance behaviors as well. One example would be if a person with OCD is fearful that they might harm others using sharp materials, so they might stay away from holding or being around sharp objects altogether. So out of worry, I mean, when a family member is telling you that they are worried they might harm other people, I think one of the natural responses we might have as family members would be, okay, we'll keep away all the scissors, we'll keep away all the knives. We will not use this when the person is at home. Okay, so this is helping them to also avoid some of these materials also. And frequently, we might find that we also have to provide a lot of reassurance to the individual with OCD. We might be tempted to tell them that hey, your hands are clean already, or the door has been locked already, nothing bad is going to happen. Don't worry so much about things. So those are provision of reassurance. And we also a lot of times see families modifying their routine in order to accommodate OCD behaviors. So for example, a family might no longer take MRTs, or because of all the trouble, they might just avoid going out as a family for dinners altogether. So all of this are what we call family accommodation. They are very similar to compulsions actually, because we are giving in to OCD when we are doing this. We have essentially been recruited to be slaves to the OCD, and the continued family accommodation is not helpful with the recovery. With the amount of stress and time that the family puts into accommodating OCD, definitely they are going to find themselves very burnt out by the care for these individuals. We put in so much time and effort to help them with their compulsions, hoping that it will somehow take away the distress, but it doesn't seem to be working. It's understandable that caregivers will really feel very helpless, very burnt out, and even anger, resentment towards the individual. But yet, if we were to stop accommodating the OCD altogether, the person will be in so much distress and hence might respond with rage and aggression, might even threaten suicide. And the whole family feels like they are really walking on eggshells, basically. So there is a lot of sadness and grief with OCD as well for families. Just to see your loved one who used to be doing so well, suddenly having difficulty even managing the simplest of tasks, such as grooming, such as walking. And there's a lot of worry about what's going to happen next for this person and their future when they seem so stuck and not able to engage in life as they used to before. So OCD not just impacts on the person, but on the entire family as well. And this is also a common dynamic that we see in families where the OCD lives, where there is usually one good cop on one end and there's a bad cop on the other end. So one caregiver might be overly kind, where they are very accommodating, perhaps wanting to relieve the individual of OCD of their distress and taking over most of the duties. But then on the other hand, we also have the bad cop who might be very harsh, very blaming, perhaps even blaming the kind parent for making things worse. And these two extremes actually often compensate for each other. So the kind one might feel bad because the harsh person is being harsh. Then vice versa. So what OCD does is splitting the family. And actually, what we also notice is this might not even happen with two caregivers. The same dynamic can occur within the same caregiver as well, where the caregiver might accommodate giving in until it becomes so tiring, so frustrating, that the person becomes harsh and blaming, and then feel guilty about it, and then we give in and accommodate again. So what we realize is sometimes we might swing between the two extremes. And with this, again, there's a lot of splitting that happens, and it's not really helpful in fighting against OCD. Okay, so what caregivers can do, firstly, it is helpful to educate yourself about OCD and what keeps OCD going. Family accommodation, I have to say, is really very intuitive. If one of my loved ones is going through something like that, I would definitely have been hoping to relieve their distress. But then some of these kind intentions, in particular for OCD, might not be so helpful, and it might actually encourage OCD to continue. So in the later part of this talk, I'm going to provide some resources that you can have a look at to understand more about OCD. So aside from encouraging your loved ones to seek professional help, it is also helpful for you to perhaps see your own therapist or be involved in a support group of your own, because there's so much stress and burnout involved in caring for someone with OCD. So if you are seeking out therapies, you might be wanting to find someone who really understands the complexity of OCD, because the usual advice that are given to family for other conditions might be a bit different from what you might get from advice for in the case of OCD. So in this case, if let's say the person is also seeking help, then it could also be helpful to attend sessions with their loved one. So you also get more knowledge about how you can support him or her. So I mentioned also attending a support group. It is helpful in letting you know that you are not alone. And we also learn from other families that are going through the same thing as well. Okay. It is also helpful for us to accept that the person does have an OCD condition. You may not be able to change him or her. Okay, so acceptance that there is a limit to what you might be able to do as well. What you can do is to encourage and support that person in seeking treatment. But if they are not willing to, then it's really going to be very tough for you to push that through. But what research has shown is that reduction in family accommodation, although it does not get rid of OCD, it does make sure that the OCD doesn't become worse than it is. But one word of caution, we don't want to go cold turkey as well, because if we take out all family accommodation altogether, it is very distressing for that person and can backfire. It could create more difficulties for that person. So instead, what we want to do is to very gradually withdraw our responses to their behavior. And if your loved one is seeking treatment, it will be very helpful to work with the mental health professional involved about how you all can go about doing this, because as we mentioned, we will be pacing the treatment along. So the professional will be able to advise you about what are some behaviors that might be able to be dropped in that particular. Okay, so the goal is to eventually drop all accommodations, but we want to go slow with them. Oftentimes as a family, it will be helpful to work as a team also. So we don't allow OCD to split the family up. When we work together, it's more helpful in dealing with the condition. It's helpful for us to see us as standing on the same side as the individual in fighting against OCD together. So OCD is the common enemy, not their loved one. Which brings me to a related note. It is helpful to find another way of relating to OCD. So you might have noticed throughout the talk how I've used language that externalizes OCD as a separate entity from the person. So we might call OCD as a bully, we might call OCD as the dictator. And it's important to differentiate that we are calling OCD the bully, we are calling OCD the dictator. We are not calling our loved ones the bully. When they ask for help in performing compulsions, we can frame it in such a way that it is not that I don't want to help you, but I don't want to help the OCD. Okay? And that is helping you. We can be very gentle and validating to the distress of the person going through OCD, but we want to be very firm and standing up and saying no to the OCD itself. Okay? And we also invite caregivers to model distress tolerance, which is tolerating that distress of seeing our loved one in distress. So it gives them the hope and the strength that they will be able to tolerate their distress against OCD as well. So lastly, for caregivers, we also encourage you to reclaim your own life back from OCD. And going back to doing the things that is your self-care, back to doing things that you love. Because when OCD makes the whole family suffer, the influence of OCD is extremely huge there. But if you are able to care for yourself, then we are able to more effectively support your loved one in their fight against OCD. So that was the part on family. Now we have learned that, symptoms, if this symptom sounds familiar to you or to some of your family members, there are various avenues in Singapore that you might be able to seek help, seek treatment, seek support from. So restructured hospital, including Sengkang General Hospital, as well as polyclinics, can provide medication as well as psychotherapy. So if you want to go for a subsidized route, just go to your polyclinic and ask for a referral to one of the hospitals, and you'll be able to get a subsidy for this treatment. Okay. And the Community Health Assessment Team, CHAT, which is located in Scape, will also offer free mental health assessments to young people aged 16 to 30 years old currently living in Singapore. There are also other options such as Clarity, the NUS clinics and JCU psychology clinics, which are university clinics that provide psychotherapy. But for these clinics, they are not able to provide the medications. And OCD sufferers and caregivers can also seek help from OCD Network. Okay, the OCD Network is a non-profit society that comprises of individuals with OCD, their caregivers, professionals, students, as well as volunteers. The OCD Network often organizes a lot of events. They can be from yoga classes to music events, which helps the individual, just now we mentioned about helping them go back to living their life thing. So this helps them reclaim their lives again and work towards healthy living. So you can check out this website over here for the various activities that they are organizing. They used to also run a support group for individuals with OCD, whereby the peers will support each other, share experiences, and provide that support. But I'm not sure whether this is running at this point in time. It might be helpful to check out the website because they will also update on when some of these support groups are ongoing. And the OCD Network also organizes a caregiver support group, which provides a platform to caregivers to support one another. Currently, this is happening on Zoom. So again, go to the website and you can register for these events. Okay. If you want to learn more about OCD, I've listed down here some of these resources, websites, as well as books that provide very good trusted information about OCD. Okay. So the first book over here is a self-help book to overcoming OCD. The second one is about the journey of someone who has recovered from OCD. And the last book is about supporting family members through OCD. These books are recommended by the International OCD Foundation. So I have been talking for the past 40 minutes or so already. I'm going to take a pause now. Okay, I've come to the end of what I want to share. So I'll be answering any questions from now on. I can see there's this Q&A in that portion. Okay, so I will be answering. Sorry, yeah.
I'll miss you look at the questions. So I'd like to encourage the rest of you, should you have a question, please post in the Q&A box, right? Questions that are related to OCD, the treatment and the symptoms, and what Miss Yu has shared with us just now. Thank you.
Okay, so the first question I can see here is about compulsive skin picking. Okay, up to 2 hours a day, and this person was wondering whether this is a form of OCD. So this is an OCD-related disorder. It's called excoriation disorder. With the compulsion, and I'm sure it taking up so much time, it's probably causing quite a bit of distress and disruption to life as well. So while it's an OCD-related disorder, the treatment is a little bit different. But there is still the similar exposure response prevention part ongoing as well. There is also an element of breaking the habit as well. So it will be helpful to actually see a professional for this in understanding more of your symptoms also. So yes, that skin picking is actually related to that. Okay, thanks for the question. Okay, now we have sorry, I'm just reading a question. I used to always check my stove a lot before leaving my house. I might actually have checked this before leaving, but somehow when I'm on my way to take the train, in some cases, I need the reassurance that I had done these checks. Yep. I need assurance that I've done this check. Yeah. Okay. So, sorry, there was a continuation to that. For a period of time, I don't do that anymore. But recently, I'm experiencing this again. Yes. Okay. So, to Miss T here, yes, this actually sounds like it is quite similar to OCD in what I presented, whereby there's a lot of checking involved. Okay, so the anxiety about whether we might have done certain things, there might be a certain fear about will someone break into my house? Okay, will I cause harm to somebody? Will things be stolen from my house? Will something bad happen? And then the compulsion in this case sounds like it is the reassurance seeking as well as the checking. So I would say this sounds more like an OCD symptom with the anxiety and the distress of not sure whether some of these things has happened. I think when we come to checking, a lot of times what we also notice is because we check so frequently, sometimes we even forget whether we have checked already. So we have to recheck and recheck again. So OCD, while it's trying to be protective by getting us to check, it actually is counterproductive because we then forget whether we have even done it in the first place. Okay, so yeah, to answer your question, yes, it will probably be OCD. Again, I'll encourage you to seek professional help in understanding. So with the medication, as well as the ERP that I mentioned just now, there is definitely help in getting you to improve in this condition. Okay, next question we have, do you think COVID-19 exhibits OCD, especially those that involve excessive cleaning? How do you help them balance what's normal and what's not normal in this new normal? That's a very good question, actually. I would say, yes, COVID-19 has definitely precipitated a lot more experiences of OCD. So to differentiate again on that, a lot of times we will ask that person to think about if your peers with the same concern, okay, your peers are also worried about getting COVID, about bringing harm to their family members if they were to go out and experience and contract COVID. If they have the same concern, do they also engage in these excessive behaviors? Okay, they might wash 1 or 2 times. Okay, they might sanitize their hands quickly and then move on in life. But if let's say we're doing again for a very long period of time, when it's disrupting to our the way that we are going about living, then that's probably not very normal in what you say in this new norm. Okay, so the criteria again, time consuming, distress, as well as whether it's impacting on other parts of your life, will be where we notice whether this is better. Okay, so just to elaborate a little bit on this part, because with the ERP, we mentioned about wanting them to be exposed to some of these germs. But in this COVID period, again, we are not going to take exposure to the extreme whereby we are getting you to touch, things on public transport or things like that. Because again, that might be what many people are not doing right now. We don't want to put also additional excessive risk on that person also. So it might be in the clinic, we already know that the clinic is kind of okay. We have already wiped it down before. So touching these areas is probably going to be very safe. So we are in COVID-19, it does make our treatment a little bit different in that we are also we are balancing what is safe for that person. Okay, thanks for that question. Well, there's quite a few questions now. Sorry, so let me. Okay. If someone has OCD for 30 years, is it possible to be cured? Sorry, I'm losing the question. Yes. So to answer your question, definitely yes. There is still hope for that. For OCD to be symptoms to be improved, even though you have had it for many, many years. I would say because of this level of the length, we might need a longer treatment time. And the thing about OCD, because I also mentioned that it waxes and wanes, it's not that OCD is completely gone from our lives as well. I would liken it to kind of being like diabetes. Okay, so when we have, even though we go for the treatment, even though the condition is steady, we still continue taking the insulin in order to maintain the condition, in order to maintain our grip over the condition. So in ERP, even after you graduate from therapy, it will be up to you to also continue watching out for how OCD is happening in your life, and then taking the steps that you have discussed with your therapist before on how you can do the ERP on your own to avoid it from continuing to impact your life. Okay. So yes, even with 30 years, there is a good chance that you can still improve with the symptoms. Okay, if the person does not want to work with the therapist, what can we do? Okay. I think we see this quite frequently actually, and I have to normalize this because ERP really does bring up a lot of anxiety and distress for that person, even though we are going at a slow pace. I mean, just imagine us being exposed to our biggest fears. We are going to feel a lot of discomfort going into that. So if let's say the person is not yet ready to work with the therapist, I mentioned that we can start off with medication first to help that person also manage their anxiety with the help of medication in order to attempt to do some of this further exposure thereafter. Okay, so not all is lost. The family can start to reduce the behaviors first. The patient can also seek out medication for assistance before when they are ready to consider ERP again. Okay. There is no point in pushing that person to seek continue therapy if let's say they are not willing to, because after all, as we mentioned, it requires that person to be very involved in the whole treatment process. Okay. We don't want them to also feel like they have no say over something.